Good morning, good afternoon, or good evening, depending on where you are joining us from. And a big welcome to everybody who is joining us either on YouTube or on the Zoom. Our session today is on the social determinants of health, and we're thinking about the big impact that the COVID-19 crisis has had on social determinants. It's really highlighted the importance of the ways in which the things that happen in our everyday life are really affecting our health. And when there's a pandemic, they also affect how we respond to the pandemic and who is most affected by it. So we've got four really strong speakers in that area to speak to you. And I'll just mention their names and I'll introduce each of them as we go along. We have got Francesco Branca, who will start, then Deepa Sinha, then Philippa Howden Chapman, and finally Michael Marmot. And if you are on Zoom, you are able to use the Q&A function to send questions to the speakers during the session. So just type your questions in there and then we will be able to respond to those. And just to remind everybody, if you've got colleagues or friends who would like to see this session, it will be recorded and you will be able to visit pmac2021.org and you'll be able to click on the session that you want. So it's not just this session you'll be able to see, you will be able to go there and access all the sessions that are part of this PMAC conference, looking at the very many impacts of COVID and how we've responded to them. So I hope that's all very clear for you all. And now I'd like to move on to our first speaker, who is Francesco Branca, who is Director of the Department of Nutrition and Food Safety at WHO, and he's based in Geneva. While he's been at WHO, he's developed a nutrition strategy for the organization and established a new nutrition guideline development process, which has included a comprehensive implementation plan on maternal, infant and young child nutrition, and which has 6 global targets. And I think Francesco is really going to draw on that work he's done at WHO today and look at that through a COVID lens. So I hand over to Francesco Branca and he will take you through his presentation. Thank you.
Good morning, good afternoon, good evening, and thank you very much, Fran, and thank you to the organizer of this PMAC conference for giving me the opportunity to share the thoughts of the World Health Organization. I will be talking today to you about the nutritional impact of COVID-19 on different dimensions of malnutrition, particularly wasting, stunting, and overweight. And we all know by now that COVID-19 pandemic has not only been a crisis for the health system, it's been a global crisis touching many aspects of social life. And certainly it has affected dramatically the food system and is leading to increased food insecurity. Why is that? There have been disruptions along the food supply chains, including transportation and distribution, transportation of food to markets. But also from the people side, there have been restrictions of movement that have impacted the access to markets by consumers. And perhaps most importantly, there have been issues around the affordability of food. There have been price increases in certain, in particular in contexts where countries are depending on the imports. There's been a decrease in purchasing power of families because of lost jobs and incomes. There have also been disruption of social protection mechanisms. And one of them, for example, has been school closures that have led to interruption of school meal programs. And unfortunately, this disruption has been particularly at the disadvantage of the fresh, perishable, nutritious food, such as fruit and vegetables, meat, milk, and other dairy products. I mean, the grains have not particularly been affected. The State of Food Security and Nutrition report published earlier this year has attempted a scenario to predict what this impact on food insecurity might be. And there are indeed several scenarios that are linked to the different potential economic impact and the capacity that different parts of the world will have to recover. Now, this report indicates that even in the current situation, we are still, unfortunately, at the level of having 690 million people who do not have adequate energy. And this number is unfortunately on the increase. But what COVID is doing is dramatically increasing. You see that even in the milder scenario, which is the dashed line, the second from the bottom, you see there could be an increase expected to almost 780 million, so about 100 million more. But this scenario can be as worse as to get us to 830 million more. So we can have an increase anyway from 100 to 830 million people. And, you know, depending on what's going to happen next year, I mean, there should be a drop anyway in this number of food insecurity, but there could be longer term effects that we need to avoid. The other, of course, important component of the COVID crisis that is going to affect people's nutrition is the disruption of healthcare services, which, of course, had to cope with the enormous burden of the pandemic, but this was at the detriment of other essential services, and particularly antenatal care services, childcare services, and community care activities. And, you know, health workers have been affected, they've been ill themselves, they've been fatigued, they've been moved to the provision of services necessary for the pandemic. There's been a scarcity of essential medicine. Some of the supply chains have been disrupted. And people have reduced their access to health services, part because of loss of health insurance coverage, part because they didn't want to get any close to the health centers with the risk of being infected, but also because the community services, the outreach services have been affected. So the counseling, the delivery of interventions have been disrupted. Several vitamin A campaigns and vaccination campaigns have been disrupted. Breastfeeding promotion had to be diminished, suspended. Nutrition counseling activities had to be reduced. And particularly in the space of breastfeeding, mothers have also been afraid that COVID-19 infection might be transmitted from them to the children. And sometimes even country guidelines have suggested the separation of mothers and children. So this has had an effect on breastfeeding. There's been an opportunistic marketing of breast milk substitute, and so this has also led to an increase in the use of breast milk substitutes. These are the data that WHO has collected from countries about health service disruptions. You can see that services such as routine immunization through health facilities have been disrupted in 61% of the countries, the outreach even more, 70%, sick child services, 52% disruption, and look at the management of malnutrition. 51% of the countries have had their services disrupted. So, you know, of course, discontinuing the services of the management of malnutrition is a tragedy where particularly children rely on these services as a life-saving element. So what is the expected outcome of all this? And a few months ago, the Lancet has published a short paper in anticipation of a longer paper, which is in the pipeline, looking at the epidemiology of wasting particularly, and looking at the potential impact that would be particularly the effect of the decrease in gross national income. And this is really based on our experience of the previous economic crisis, where this data have been collected. Let's say, mild estimates or moderate estimates indicate that there should be a decrease of about 7.9% on average of gross national income, which would actually bring 140 million people more in extreme poverty, so less than $1.9 per day in 2020. And this is combined to the health service disruption we were discussing. In particular, I'm just mentioning, but this is just one of the elements of the health service disruption, the 51% of countries reporting disruption of wasting management services. So this is likely to produce an impact on wasting, and this would mean additional 14.3% children with wasting, which is about 7 million children. And this is on top of the 47 million children that are estimated to have been wasted until 2019. So that's the dimension of wasting. We're still not able to make an estimate on stunting, but the paper that is about to be published does that. So we will also have a number there. Of course, while wasting is something that can be documented in the short term, the effect on stunting is actually going to be longer term, and it will see that effect in the next couple of years. But I also would like to talk about another dimension, and that's the dimension of overweight. The World Health Organization has developed a strategy on childhood obesity based on the results of the Commission on Ending Childhood Obesity. And that commission is having a number of recommendations, and we've tried to analyze what would be the effect of the COVID-19 pandemic on all those measures. And you can see that many of those pathways are actually going to be influenced by COVID-19. As we said, there is reduced access to fresh food, which we start to document in a number of countries. There are some worrying data, particularly from Latin America. Reduced mobility, people confined at home, children who are not able to be active at school, increased screen time, but also reduced access to antenatal care, messages discouraging breastfeeding, increased promotion of breast milk substitute, disruption of school feeding programs, reduced access to counseling services. We do not have as yet data, structured data about increase in childhood overweight, nor of course in adult overweight. So we have only anecdotal information about that. It seems to be the case at the moment, particularly in high-income countries where some of these phenomena have been more well documented. But what we can say is that there is another effect, and that is the association between overweight and obesity and the impact of COVID-19. And this is true both in adults and children. This is the result of a meta-analysis recently published under the lead of Barry Popkin. And you can see that, although we have a pretty broad range of documented effect, the pooled data effect are that individuals with obesity have twice the risk of hospitalization with COVID-19. But please do look at the range. In some cases, in some studies, this odd ratio can be extremely high and very much higher than 2. So what is the response to that? The lead, the executive director and director generals of the organizations that are dealing with nutrition in the UN, UNICEF, FAO, WFP, and WHO have issued a call to action in which they advocate for 5 urgent actions to protect children's right to nutrition in the COVID-19 pandemic. Number 1, safeguard and promote the access to nutritious, safe, and affordable diets. Second, invest in improving maternal and child nutrition through pregnancy, infancy, and early childhood. Third, reactivate and scale up services for the early detection and treatment of child wasting. Fourth, maintain the provision of nutrition and safe school meals for vulnerable children. And last but not least, expand social protection to safeguard access to nutrition, diets, and essential services. This is what is happening. The UN organizations are working with governments to make this happen, particularly to implement a roadmap for wasting reduction. We already were in a crisis, as also the panel on the in the top right bubble indicates. Those numbers have not faded. Number of wasted children, we're still waiting, dealing with more than 5% of children under 5 with wasting. So that's a crisis that needs to be addressed anyway, but now even more. Stunting has been decreasing steadily in these years, but unfortunately we predict that that trend will be deflected and reversed in the next couple of years. Overweight also has been on the rise, and we unless we take drastic action, that's not going to happen. But this is actually indeed in our power, so we're very pleased that we're all having this collective discussion. Next year, we will all be working in the UN Food System Summit. We will have a summit on nutrition for growth. We're in the middle of the decade of action on nutrition. So this, of course, this crisis is disastrous for nutrition, but we can all work to reverse its effect. Thank you very much.
That's wonderful. Thank you so much, Francesco. I think you just highlighted the way in which COVID has really made poor people's lives much worse. And I just reflect on the fact that I was reading today that at the same time as you're describing 140 million people thrown into extreme poverty, the wealth of billionaires in the US has increased by $637 billion. So it's quite a dramatic picture that's happening in our world in terms of inequities. So that was really good. And I think we're going to stay on the theme of food. And I'm very, very happy to introduce Deepa Sinha, who has an academic background in economics and development, as an assistant professor of economics at the Ambedkar University in Delhi. And perhaps most importantly, she's combined her academic career with being an activist, particularly in terms of food right, nutrition and public health. And she's worked with the Office of Commissioners to the Supreme Court on the right to health. And she is very actively involved with the Right to Food campaign. And I'm very pleased to say that many of my PHM, People's Health Movement colleagues, work very closely with the Right to Food campaign that Deepa works on. So over to you, Deepa, to give your perspective on the impact that the COVID has had in India.
Thank you, Fran, and the conference organizers for including me in this panel. And I'm also glad to be following Francesco's very comprehensive presentation, which looked at the impact of COVID-19 on wasting, stunting, and obesity across the world. So what I will be doing in the 10-12 minutes that I have is basically talk about these same issues with some data and examples of what has been going on in India to the right to food in the context of the COVID-19. Like everywhere else, the COVID-19 has been, of course, a crisis of health and access to health services, but at the same time also has brought about along with it the lockdowns and because of that, the economic crisis. And what we see is that across the world, that both of these together, the economic crisis and the health crisis, is resulting in a food security crisis where even hunger and near starvation conditions is back in many parts of the world which had got rid of it. In this context of looking at the impact of COVID, definitely in the case of India, but overall, it's also relevant to look at the pre-COVID context, where over the last couple of decades, we've been seeing increasing inequality within countries between the rich and the poor. Also high food insecurity and high malnutrition continuing to remain in some parts of the world. In India, in the third week of March, a national lockdown was announced without much warning, because of which we've seen some very detrimental effects on hunger. But even before the lockdown was announced, just a few facts of what the Indian economy and the lives of people looked like. More than 90% of workers in India of the labor force is in the informal sector. About 80% earn less than rupees 18,000 a month, which is about $240 a month. All of this is official nationally representative data. The 2 years back, we had our unemployment survey data being brought out, which showed that India was facing the highest unemployment rate in 40 years. High malnutrition rates continue despite great improvements over the last 10 years. We still have 38% of our children under 5 being stunted, and almost 20% children being wasted. And since 2015, along with an economic slowdown, what we have been also witnessing is a comeback of reports of hunger-related and starvation deaths in the media and by activists of the Right to Food campaign from different parts of the country. At the same time, while we have on the one side the situation of high vulnerability and precarity of people in the informal sector, we have also seen in the last 10-15 years the introduction of the National Food Security Act in 2013, which followed up on a number of Supreme Court orders, which expanded a whole range of food and social security programs to cover a large population. Therefore, India does have a strong institutional framework, particularly for food entitlement programs, subsidized food, school meals, early childcare centers, which provide supplementary nutrition, and so on. Also, when we entered COVID-19, it was also a time of unprecedented levels of food grain stocks in the government stock that India had. So we reached about 90 million tons of rice and wheat in the stocks, which is much, almost 4 times what the government is required to be holding. The national lockdown period of April and May 2020, which was a complete lockdown across the country, which is also many international indices which are calling it one of the most stringent national lockdowns. And now within the country, it's more or less a consensus that it was ill-planned. This resulted firstly, and this was the most visible crisis, a massive crisis of stranded migrant workers. So overnight, when the lockdown was announced, we had most of our workers in the informal sector who live on their current incomes without many savings, and especially those in the urban areas who come from rural areas. The minute their income stopped, it was very difficult for them to pay their rents, to buy food, to do anything. So what we saw was that with the lockdown being announced and public transport being shut down, thousands of workers just setting out on foot, working hundreds of kilometers, going back to their villages. And obviously, that was the most visible sign of the livelihood crisis which we were facing, with all economic activities stopped for over 2 months. As a result, food security and a hunger crisis, where in these 2 months, a number of phone surveys that campaign groups like what I'm associated with and various universities conducted, all these surveys show very high levels of hunger and reports of starvation. So obviously, these surveys are not random representative samples. They are phone surveys, so they're based on the phone numbers you're able to get. But if all of these report, over 2/3 of people reporting loss of income, a high proportion of people reporting eating only 1 meal a day, and so on. There was one group which put together just verifying newspaper reports on deaths due to non-COVID reasons, and they classify it by what the newspapers reported. And that group, which from April to July, recorded that over 200 deaths due to starvation and financial distress was reported during this period of lockdown. And then, of course, like Francesco said, in India too, we saw the closure of schools and early childcare centers, which are an important source of nutrition, especially for women and children. And schools and early childcare centers are still closed. They've still not reopened. So the post-lockdown, now I'm talking about after May. So April, May was the national lockdown. From June, we've been slowly opening up. Various activities have been allowed, except schools and educational institutions. But we see that hunger still remains. It is a serious issue. The one data we have of the economic impact is that the first quarter of 2021, April to June, there's a 25% reduction in GDP on a year-on-year basis. There is some revival of economic activity, but this is still very, very slow. As the supply and distribution chains have all been disrupted, it's taking a long time for them to come back together, and there is a deep deficit in rural demand. Various government support programs, which were announced as a response to the lockdown and the distress caused by it, are also now coming to an end, which is leading us to be even more concerned about the hunger situation. So I'll just quickly share a few figures of this process called the Hunger Watch that we have just completed. We have not put out the report yet, which is an initiative of the Right to Food campaign, along with a number of other civil society organizations in India. It's also the first survey where we've actually done face-to-face interviews. These were not conducted over the phone, but it focused particularly on vulnerable groups, on people in the informal sector, those belonging to the tribal communities, forest communities, homeless population, and so on, conducted in September, October, with about 3,500 households. And this whole process also involved immediate action on the ground to identify families which are in starvation and to link them to government relief programs. So like we can see, just quickly going at, so the questions asked people their perception on what their food consumption was like in this period of 30 days before the interview was conducted, compared to before the lockdown, around February, March of this year. But almost 60% of the respondents said that their current incomes are less than what they were pre-lockdown. These are already low-income households. Half of them said that they've reduced their cereal consumption, over 60% that their pulse consumption, which is the main source of protein in most Indian diets, said that that is reduced. 70% said, and this is where we see the price effect, because in terms of prices increase, we saw it most in fruits and vegetables. 70% said that they reduced their vegetable consumption, and also consumption of eggs at over 2/3 had reduced. In terms of their perception of quality and quantity as well, 2/3 of the respondents felt that it had worsened compared to February, March this year. 45% reported that they needed to borrow money for buying food. And the last bar, which is a little sad, is that almost, again, 30% of them expected that the food security situation would only become worse in the coming months. In this context, we also asked about their access to the food schemes that the government did have running during this period. So about 70% of them did have a ration card. A ration card is what gives people subsidized rice and wheat in under the public distribution system, and this is what comes under the National Food Security Act. So 70%, which is the National Food Security Act, also mandates a coverage about 70% of the population who had the card. Amongst them, over 90% said that they were getting free rations. However, where the schools were closed, they were supposed to get some take-home rations or cash, and that was lower, only 60%. And less than half of them in the preschool age group and the under threes were getting any dry rations or cash. And once again, this is not the period when we had the full lockdown. We're talking about 30 days before the survey, that is September, October of this year. All of this basically goes to show that while there is some social protection from the government schemes, the situation of hunger is still quite stark. And this is important for us in India for these survey results, because the government is also in some ways arguing that with the end of the national lockdown, things are back to normal because people can go out and work. So I'll quickly conclude because I have about a minute left. So there has been a government response, But the issue has been that it has been too little, possibly too late, because the response came after the lockdown began and the migrant crisis started, and probably also ending too soon because the free grains that were being distributed to those who have cards ends in November, and as yet there has been not been any announcement that it will continue from next month onwards. There have also been issues of people being left out. So while we found that 70% did have ration cards, the other 30% who were also very belong to vulnerable groups did not have ration cards. And the problem has been that most of the government schemes and relief that has been announced has only been for those who were already part of the system, whose names were already in the lists of the various social protection schemes that the government runs. So from all of this, just quickly, my conclusion points, what we have learned for India, and I think it's probably relevant to many other developing countries, one, that universal entitlements are important. And at times like this, those who get excluded from these different lists are precisely those who are most marginalized. And the way to reach them would be to universalize entitlements. Also, that COVID response rooted in existing structures have been the most effective in India. So the public distribution system managed to reach many, many more than the newer schemes of trying to reach cash to people post-COVID that was tried here. That as a campaign and from part of the right to food, we see this as an opportunity to also strengthen the social protection food entitlements framework in a larger food systems approach, because it's not just about the rice and wheat and the hunger, but linking to what Francesco was saying, if we have to reduce the impact on overall malnutrition, then we have to look at diversifying diets, which would mean reimagining procurement, distribution, and the reimagining the entire food system. So I'll just conclude, thank the organizers once again, and would end here. Thank you.
Thank you so much, Deepa. That was a wonderful description of your research in India and really a very fine-grained analysis of what's happened with food security. And I really like the way you combined your evidence with the policy implications. That was really excellent. So thank you very much. I'd just like to remind people before we go on to the next speaker to ask your questions. You can type your questions as we go, and we will have the question and answer session at the end. So please, as you're listening to the speakers and things occur to you, then please put them into the question and answer now. Don't wait until we open that session, because then your question will probably be down the list. Okay, well, now to introduce our next speaker, who is in the same region of the world as me, well, not quite, a bit further and later around the globe. Professor Philippa Howden-Chapman is a professor of public health at the University of Otago in Wellington in New Zealand, and she teaches public policy. She's also director of the He Kanga Oranga Housing and Health Research Programme and the New Zealand Centre for Sustainable Cities. And I think Philippa's real claim to fame is the randomised community housing trial she's done, where she's produced really strong evidence that if you improve housing, it really affects people's health. So it's a really important body of work. And not surprisingly, she's currently the chair of the WHO Housing and Health Guideline Development Group. And she's also won the New Zealand Prime Minister's Science Prize in 2014. So over Philippa to tell us about COVID and housing as a social determinant.
Good evening. Thank you for that very generous introduction, Fran, and thank you very much for the organisers for including housing in it. I'm just going to share my screen now. It's evening here. Can you see that all right? Oh, well? Okay, so I'm addressing the question about one of the key social and economic determinants of health, which is housing. And I had a privilege of working with Michael Marmot in the London School of University College London, just after he'd done the social determinants of health with Fran. So it's a great honour to be sharing the platform with them both. My key message about housing in the pandemic is that housing is really a key determinant of health and well-being. And I'm very keen on paintings, and I like this one in particular because the house was centered to life around it, dancing, relaxing, and so forth. Housing is really interesting as a determinant of health because it's a private space. It's where you can go to be intimate, to relax, to have friends, but it also has public benefits. And it also can have costs because if your house is damp and cold, or if it's too hot, then we know that's very bad for respiratory and cardiovascular health. So as Fran said, I've concentrated my work on broad co-benefits of housing, which match very well to the SDGs. And our government, I come from Aotearoa, New Zealand, has introduced the first wellbeing budget on the basis that rather than just concentrating on the economy, actually we're going to advance broad wellbeing. And so we're just doing a big research project on public housing, which looks at the social outcomes, environmental, economic outcomes, environmental and cultural. And we have an Indigenous population in New Zealand, about 15% of the population. So we have time use studies in New Zealand, and we looked at how much time people spent inside the house. This is self-report, people kept diaries, and we're surprised to find in New Zealand it was 75% of the time, and we expected that we were all going to be outside on the beach or in the mountains. But in fact, it turns out to be very constant throughout the developed world. And young children, older people, and disabled people spend about 90% of their time inside. And of course, many of us have been in lockdown where we've been spending even more time than that inside. So the quality of the indoor environment is absolutely critical. But in countries like New Zealand, there's no ministry, there's no policy agency that looks at the indoor environment. There's a lot of emphasis on the outdoor environment, but not the indoor environment. So I had the privilege of working with Carlos Dora and Natalie Rebel at the WHO, chairing the Housing and Health Guidelines Group. And in 2018, we finally got through a decade-long effort to actually say, what is the evidence and what should we really focus on? And the very strong evidence came through that that temperature was a key issue. Being very hot in your houses, being very cold in your houses, both were very bad for health. If the house is damp and moldy, that's very bad for health. If it's polluted, of course, by burning solid fuels inside the house, and in New Zealand, until our research was coming along, people had unflued gas heaters, which were very bad for health. And I'm just trying to shift this so I can see. Oh, yeah. And the last thing is that houses should not be crowded. And in fact, that was the strongest guideline that we had. All societies actually like celebrating inside houses and so forth. But as that saying, Southern Italy goes, fish and guests begin to stink after 3 days. So basically, if what has happened in COVID, as many New Zealanders come back to New Zealand and people have been evicted, is that there's a lot of overcrowding in houses, and that has led to some of the local outbreaks of COVID. Sorry, just okay. These are the guidelines that I talked about before, and we've one of the articles that we've written about the standards, and this is my favorite cartoon. This is the landlord who we've had a sort of campaign, who's had a campaign against us in the papers, and in our work we've introduced rental warrant of fitness to try and improve the standards of private rental housing, which are poorer than home ownership. And this man is slapping. This was a real man called Mike Butler. My tenants will freeze over before I apply this 2008 insulation standard. There is no evidence that a minimum 18-degree temperature is healthy. Who puts out these fevered claims and guidelines? And this cartoon, the man running away, is the World Health Organization. So I have that framed in my room. So the work of the institutions like the WHO and Habitat around the SDGs and setting guidelines can be very important. The role of government is really critical in picking up one of the lessons of the Michael's report and work that Fran Bowen did, is that the issues about power and the government in many states, as we know from the American election and the election we just have, is absolutely critical about what policies are chosen. And in New Zealand, like Taiwan, we have the enviable example of having a progressive government with a very charismatic leader. And we followed the elimination strategy of go hard and go early. We have a population of 5 million, about the same size as Ireland. But we've had 25 COVID deaths, and largely due to very good tracing and the fact, of course, we are an island and we can look at the borders, close the borders, and people have to go into quarantine for 2 weeks when they come back. Even so, 1.5 million New Zealanders live overseas, and a good proportion of them want to come back by Christmas. And so we've got rather a lot of crowding in our quarantine places. There's a bit of a tussle about who can improve the housing in New Zealand. The government has to trust, the public has to trust the government to restrict individual liberties for the greater good. And during the whole period of COVID, it was really interesting. We had because of low interest rates and a rise of overseas people buying up houses in New Zealand, there's a big increase in rents and evictions. And during COVID, the government brought in that there were not allowed to be any evictions, and everybody was to be housed in transitional housing, if not permanent housing. And that was really extraordinary to see that with the right kind of strong policy direction, there was then no homeless people on the street at all. And the strong social capital increased the collective capabilities and resilience in the country. And our recovery has very much been based on well-being's outcomes. I've got the privilege of being on the board of the largest Crown enterprise in New Zealand, which has $8 billion to spend on public housing. There was a big emphasis on that people could have still continued to be build houses during the third level of lockdown training, employment, and the government has authorised this Kāinga Ora, the body to build homes and communities, to borrow $8 billion on the foreign exchange to fund public housing. And these bonds sell very quickly on the basis that people want to be able to do good with money. Nonetheless, there are still huge challenges. There is an economic recession, although not as bad as we thought it was going to be, but we've now got 5% unemployment. And I mentioned the increased repatriation, leading some of these were people who have bought homes while they were overseas, and now they want to get into them, obviously, but that's led to another round of evictions. There's a big shortage of affordable housing, an increased waiting list for public housing where people only paid 25% of their income. So there's rising homelessness again. And this is outside our town hall where someone made a little house there. At the same time, and it's raining quite hard outside at the moment, escalating effects from climate change surges and flooding. And most of the cities in New Zealand, as in many parts of the world, are built in basically wetlands on harbours. This is some of the public housing just across the way from me, which was refurbished. This is council housing, and this is what the kind of things that we're building. This is actually a refurbished one from the 60s, and one which the cars are on the outside. It's a lovely place to play for children, quite a large proportion of refugees and migrants there, and a big amount of very supportive services. And that's one which I like to think is a kind of means that people on very low incomes can live in the centre of the city and have access to parks, good schools, and be close to the sea. So one of the things that we really look at in terms of housing, it's not just housing, it's communities. You need good environmental outcomes. with easy access to public space, blue, in other words, water, and green space and parks. And the other thing that is often neglected when we're thinking about social and economic determinants and so forth is the idea that there's cultural well-being, and this is one of the marae, Te Ao Marangi in Christchurch in New Zealand, which actually signifies, you'll see here the settler community as well as the marae and the gates and the traditional meeting house, which is like some in Malaysia and so forth, because that's where Māori came from originally. So the government has very active partnership with Māori, iwi, tribes and community providers to support Māori advancement. In other words, every policy that is now undertaken when the government's just been elected for another 3 years, the first decision is how does this help to advance the position of Māori who've got lower home ownership and lower incomes than other people in New Zealand. So this has become the paramount policy. And this is really annoying at the bottom. I hope it's not blocking it off for you people. This is more public housing, and in the meetings when we're building it, my question is always, how close is it to public transport? How close is it to park? And we need to support the transition to a low carbon economy. 20% of carbon emissions come from construction, and we're very aware of that, both in terms of the embodied carbon and energy use in the housing and use of public transport and renewable energy. So in summary, the pandemic was pretty dramatic in New Zealand, and in like other countries we've been in lockdown, but not nearly as long. But it can be contained with quarantine and concerted contact tracing. Government power, I think, which we don't often talk about, but needs to be exercised in partnership with the city councils and Māori. And government leadership is vital in terms of the trust and the borrowing that it can do, and the implementation of regulation vital for carbon emissions. And social inclusion is very critical to build trust and investment in public good. And interestingly enough, in New Zealand, although there was, many of the health indices are better actually when people are home. We've had a much lower rate of small for weight babies. There's been fewer road traffic accidents because, of course, people weren't in their cars during lockdown. And so a number of indicators are actually very positive, even though there were still deaths. And my final point, which I'm very excited about, is that you can, from COVID-19 transformation, or the money that has been put into the Keynesian policy to improve things, there's been a big increase in public and affordable housing and big civil engineering infrastructure policies to ensure that the cities are more resilient and the communities are more socially inclusive. Thank you very much. I look forward to your questions.
Thank you so much, Philippa. That was a really wonderful example of how producing the evidence on how housing affects health can make a real difference. And I'm sure that your research has fed into the current Ardern government having such a great strategy on public housing. So well done. And I'll put you on notice, one of the questions I'd like you to tell us more about is the New Zealand wellbeing budget. But if you hold that thought, and we can think about what to say about that. Well, now it's my pleasure to introduce Professor Sir Michael Marmot. And when people introduce Michael, they usually say he doesn't need any introduction, but I'm going to say a little bit. I think everybody knows he's director of the Institute of Health Equity at the University College of London. And of course, he's published some very well-known books, The Health Gap, The Status Syndrome. And in the last now 12 years, he's led a number of reviews of social determinants of health. And I was privileged enough to serve under Michael on the Commission of Social Determinants of Health. And I have to say, for me, it was a career highlight. It was a place where we made lots of friends, but we also did amazing work and thinking with a whole network of knowledge networks about the social determinants of health. And since then, Michael's done similar reports for Europe, for the UK, for PAHO, WHO region, and it's really has put health equity as a big policy issue on the agenda. So, and I think the most important thing I should mention at this particular seminar is that Michael won the Prince Mahadol Award for Public Health in 2015. So he is a PMAC laureate. So over to you, Michael.
Thank you for this symposium. I'm going to talk about social determinants of health and the pandemic. Let me start, though, with a hurricane. This was put together by the UNDP, Human Development Report, and the effect of Hurricane Maria in Puerto Rico. And you can see the excess deaths are high in the lowest socioeconomic group, then still elevated in the medium socioeconomic group, and least in the highest socioeconomic group. Any external shock, like a hurricane, a pandemic, is likely to reveal the underlying inequalities in society and to amplify them. The opening line of my book, The Health Gap, was why treat people and send them back to the conditions that made them sick. The healthcare system is absolutely vital, but as with the others in this symposium, I want to talk about the conditions that make people sick. In February 2020, before the pandemic crashed upon us, my colleagues and I produced this report, Health Equity in England, the Marmot Review, 10 years on. After the WHO Commission on Social Determinants of Health, I was invited by the British government to produce a Marmot Review of applying the global recommendations to one country, England. And then I looked back at what had happened in the last 10 years. And my summary was, we've lost a decade, and it shows. Life expectancy increase, which had gone on for 100 years, and about 1 year every 4 years, slowed dramatically and ground to a halt. And when we look at the improvement in rich countries in life expectancy, Estonia, Norway, Slovakia, Hungary, across Europe, there's the UK, and the only countries with a slower increase, one other European country, Iceland, and the United States. So pre-pandemic, we were not doing well. And my argument has been that the health of a society tells us a great deal about how well that society is functioning. And in the UK, our society was not doing well pre-pandemic. And then when we look at what happened with the pandemic, this is excess deaths. So it's not just COVID-19 deaths. We look at how many deaths would be predicted to have happened in 2020 if the rates of the previous 5 years had applied, and then the excess. The excess in England was higher than in Scotland, and the excess in England was the highest in Europe. So pre-pandemic, we had a slowdown in health, the worst virtually of any country except the US. And during the pandemic, we had the highest excess. Not good. And more to the point, the same set of influences that relate to our less than perfect health condition pre-pandemic tell us a lot about what's going on with the pandemic. We classify here people by the level of deprivation of residents, and the gray is all causes. The greater the deprivation, the higher the mortality, a social gradient, and then the blue is COVID-19, a very similar gradient, which means the causes of health inequalities more generally overlap with the causes of inequalities in COVID-19. The excess here at the bottom, we think, is related to being employed in a frontline occupation and living in overcrowded multi-generational households. And if we look at ethnic differences, women, Black British, strikingly high mortality from COVID-19. The blue is adjusting for deprivation and geography. And a large part of that excess is related to deprivation, and similarly in men. When these data were published, our health minister was on the BBC and he said, very bad situation, people should wear masks and wash their hands. And I was asked by the BBC, what did I think? I said, that's good advice. And we should deal with structural racism. But what should we do tomorrow? I was asked. Tomorrow, we should start dealing with structural racism. In my 2010 review, I had 6 domains of recommendations. Give every child the best start in life, education and lifelong learning, fair employment and good work for all. Number 4, everybody in a rich country should have at least the minimum income necessary for a healthy life. Healthy and sustainable places and communities, and that includes housing, of course, and strengthen the role and impact of ill health prevention. What happened over the last 10 years? Well, in 2009-10, 42% of GDP was in public expenditure. With the global financial crisis, the government decided to roll back the state austerity, and that 42% went down to 35%. And the rolling back of the state, the reduction in public spending, was done in a most regressive way. The gray is total spending by local authorities per person, by level of deprivation. So in the 20% least deprived areas, the spending per person in local government went down by 16%. And then the greater the deprivation, the greater the reduction in spending. So in the most deprived 20% of areas, it went down by 32%. The greater the deprivation, the greater the need, the greater the need, the greater the reduction. Sharply regressive. I want us to think now globally what we're going to do as we come out of the pandemic. And the Human Development Report for 2019 looked very much at capabilities. And they looked at what they called basic and enhanced capabilities. So, for example, a basic capability would be life expectancy at birth. Human Development Group countries, low, medium, high, and very high. You see the inequalities. And an enhanced capability would be life expectancy at age 70. And again, you see the inequalities. A basic capability would be population with primary education. Very clear inequalities among countries. And enhanced capabilities would be population with a tertiary education and very steep inequalities. A basic capability would be mobile cellular subscription, a mobile phone. And as we know, access to mobile phones have increased dramatically across the world. Even in low human development countries, it's 67 phones per 100 inhabitants. Fixed broadband subscription is an enhanced capability. So what's been happening? There've been slow convergence in basic capabilities, rapid divergence in enhanced ones. So life expectancy at birth, declining inequality, great. The reduction has been, the improvement has been greater in low human development countries. Life expectancy at 70 has gone the other way, increasing inequality, and the improvement has been greater in very high human development countries. We've got increased inequality in enhanced capabilities. And enhanced capabilities should not be a luxury for rich countries. We should want increased life expectancy at age 70 for countries at every level of development, but the inequalities are increasing. Share of the population with primary education, it's gone up, but it's gone up more down here with low human development. So the inequalities are getting smaller, great. Share of the population with tertiary education, oh my goodness, it's gone up more in the very high human development. So globally, the inequalities are getting bigger. Related, some figures, I think, Fran, you said this earlier. Has COVID-19 been the great leveler? In the US, from March to September, Americans 643 billionaires increased their wealth by 29%. That's $845 billion. At the same time, the hourly wages of the bottom 82% of the workforce declined by 4.4%. 60 million of these people voted for the President of the United States. And I want to pick up what Philippa said. As we think about emerging from the pandemic, I would like us to follow New Zealand. The New Zealand Treasury put a well-being approach at the heart of what they're trying to achieve, which can be described as enabling people to have the capabilities they need to live lives of purpose, balance, and meaning for them. That, I argue, should be at the heart of building back better. Thank you.
Thank you very much, Michael. That was wonderful. And as usual, you've managed to point out the direction we're going in as a society, the dangers of that, and ended with a very positive message supporting Philippa of what we can do. So thank you. It's fantastic. Now, the questions are not running thick and fast, but we do have one, which is from Dr. Unkushak, I hope I'm saying that right. And he's asked, what could a wellbeing plan in lockdown be like? So I don't know, I think, Philippa, he asked that during your presentation, and I remember you talked about the lockdown. So I'm sure Deepa also may have views on that. But Philippa, maybe if I go to you first and then to Deepa.
Thank you for the question. Well, in New Zealand, there was a big effort to build up social capital. We are sharing this together. The Prime Minister talked about the team of 5 million. There were things like people put teddy bears in their windows, and so the children could go around and look at teddy bears. I've got a whole series of photos about graffiti on the side of walls, go home, we love you. So there was a very a strong sense that it wasn't easy for anyone, but we were there to help each other. And so it was a very intense and quite emotional period. So I think, and that was followed by a very interventionist government, lots of money to small businesses, and increasing money, huge amount of money went out from the Reserve Bank and quantitative easing. So there was money flowing into the economy. The epidemiologists had very strong advice that was received. In the Kaingora, the big organisation that I work for that has 66,000 tenants, they were phoned every week to see they were all right, did they have enough food, did they, and so forth. So there was a real sense of caring and sharing, and so it was actually a very intense but quite a positive time, really.
And
although it did highlight many. Yeah.
I'm surprised you haven't mentioned the leadership of your Prime Minister.
Oh, yes. Well, no, I did allude to it. Yeah, she is extraordinary. And she's very frank, not least she was on CNN last night saying, I just don't understand America. So I was kind of, she's, just at 40 and just had a baby, and she's pretty amazing. And so people really respond to her. I think leadership is absolutely critical,
Yeah.
as Michael's shown, as we've seen from many other countries. And people will do things if they feel other people are doing them too. And the First Minister of Finance, the First Minister of Health went on a cycling trip when he wasn't supposed to be, and he was basically sacked first time, so that you've got to make a good example.
I think Michael could give us a contrasting example from the UK, but Deepa, would you like to talk a little bit about what you think are really what would a well plan be for a lockdown in India?
Yes. So I did say in my presentation that the lockdown in India was ill-planned, and
yes.
It was totally in contrast to what we've been hearing about countries like New Zealand. So what happened in India was that we had a 4-hour notice for the national lockdown. The Prime Minister came on live television at 8 o'clock and said from midnight, the country is going to be closed for 3 weeks. And then it kept getting extended. And given the kind of figures that I showed about the extent of the informal sector and people who are migrants, dependent on daily wage, it should not have been completely unexpected that something like this would cause great chaos, if not anything else. And so closing down, so for me, a well plan would be at least something simple like giving 4 days time, telling people that go back to your homes, go where you need to, because for the next month, you're not going to be able to work or move, at least that much. Telling people if you need to take credit to buy food, do that, just be ready. Setting up the soup kitchens, which took them a week to do after they announced the lockdown, doing that before the lockdown began. So just these immediate kind of relief measures and warning people and giving people time, even if the government is not there to support them, at least giving them the time to make their own arrangements was something that was missing. And it did cause a lot of hardship, which was, in my mind, really avoidable.
Yeah. Okay. Well, thank you, Deepa. The next question I'm going to direct to Michael, and just say as a preface that now, some 12 years ago, we published a report saying we need to close the gap in the generation. And in fact, what we've done is, or what's happened in the world is that we've enlarged the gap in a generation. And the question here is, what is the hope for addressing these challenges in public health and social determinants of health when there is a clear lack of political will and vision?
Well, I think it's very important to push where you can. I push on doors. If the door's open, then we go in. So, for example, let me start with the UK. The national government, as I've just shown you, it has a sorry record over the last decade. So we've been working with cities. If we can't get the national government to respond, we work with cities and with regions, with Coventry, with Greater Manchester, with Gateshead, Chestermere. In Italy, they've been working in the city level in Trieste, in Bologna. So a government like that in Costa Rica is very sympathetic to these ideas. We can work with the national government. But where national governments won't, then it's important to work at a different level. And Fran, you will remember at the beginning of our Commission on Social Determinants of Health, I said pretty much what this question was about. Look, if national governments are not interested, or worse, we're sunk. And Mirai Chatterjee, as leader of a non-governmental organization, a civil society organization, said that's not right. If we can't get government to act, then a civil society organization can act, and we put pressure on government to change. So where we can't get government to take this on, then civil society becomes increasingly important.
Yeah, okay, thank you, Michael. Well, we've got another question here, Deepa, that I think is directed to you. I don't know if you've read it, but it's basically asking you about the differences between the different states in India, I think. And when you consider political differences, they become a question of prime concern between the centres and the state. So, and I think your book has written about those differences. So would you like to address that question?
Yeah, so yes, there are many state state-wise differences. So the case of the South Indian state Kerala has been talked about and documented quite a bit, where not just in their response to COVID in terms of contact tracing and the kind of health system response, even on the aspects that I'm talking about. So even before the lockdown was imposed, Kerala started the system of delivering cooked meals to school children in their houses because schools were closed before the national lockdown happened. They announced a social security package for old age pensioners and people registered in various informal sector workers' boards before the national lockdown happened. There are instances where they made arrangements for migrants who were stuck to, even be able to watch TV in their local language in areas where they were staying. So there have been some state governments which were more sensitive than the others. The problem, of course, was that it seemed as if the state governments also didn't know that this national lockdown was going to come. So it was very centralized and without warning. But in terms of the data from our survey, yes, we have differences, but I don't have them right now. But we do see again, and these interstate differences are seen in India often. The southern and western states do better than the central North Indian states, and we find that in our survey as well.
Okay, thank you very much, Deepa. The last question to come in, I'm going to go to, and that person says it's vital that the role for government in managing this pandemic, including health systems and food security, housing environment, and also, are there any examples of how civil servants or others are doing this situation? So I think that's public sector responses, and we have heard those from Philippa. But I wonder, Francesco, if you can point to any positive examples in terms of food security.
Well, I must say that public leadership has been critical in many countries, for example, to protect the efficiency of food systems and to really issue adequate regulation that, for example, would allow safe access to markets, avoiding panic buying, and also, of course, making sure that the adequate purchasing power was there. We haven't seen unjustified increase of prices. That's been pretty much under control. So I would say that leadership was really important. On social protection, that's where the weakness of the existing systems have been apparent, and in many countries it was actually civil society who could come in and help. When it comes, for example, to access to food by elderly people. There were a lot of even sometimes improvised solidarity efforts in neighborhood. That was very important. But at the same time, in the space of food distribution, we have seen, in fact, this is a almost single sector that has not had a decrease in sales. In fact, it has an increase in employment. So public leadership important, but also civil society and spontaneous community response. I think community solidarity has proven a very important resource in this pandemic. We, I must say, however, do not have the full picture. The response in different countries have been extremely variable. There's also been a bit of a lack of harmonization in the kind of guidance provided. Sometimes within a country, so many discrepancies between subnational entities. So a lesson that we have learned in WHO is that it is important to have a clear guidance as much as possible. The complexity in all this is that we were in completely uncharted territory, and some of the measures. Of course, we need to be evidence-based, but for some of the measures, it was very difficult to have that kind of evidence. But very important lessons for the future. Thank you.
Okay, well, thank you, Francesco. The next question, someone's asked about mental health. And I know I was hearing some data today from Australia that in Victoria, where we've had a lockdown, there's been a huge increase of presentations and hospitalizations for young people with eating disorders. So just as an example, but I don't know whether any of the other speakers would like to comment on these sort of mental health impacts that have come both from, not so much from COVID itself, but from the responses to COVID.
Oh, Fran, if I could comment. I mean, I've been saying since we started involved with the Commission on Social Determinants of Health that anybody concerned about mental health has to be concerned with the social determinants of health. And anybody concerned with the social determinants of health has to be concerned with mental health because it's a vital outcome. And then we see what's happening with the pandemic. And predictably, calls for help from women subject to domestic violence have gone up with the pandemic. In a way, that's a sign of mental illness, of dysfunction. In the early stages, interestingly, and it relates to what Philippa was saying, I think, certainly in Britain, in the early stages, surveys suggested depression went down. And it may well be that collective solidarity that happened.
The Blitz effect.
The Blitz effect. It brought out the best in people. And I think what happened when we went, at least in Britain, from having a sort of uniform approach to lockdown, we're all in this together, to chaotic reopening, then you lose that community solidarity. While it was very clear that the reason you engage in socially protective behavior is not just for you, but it's for other people. You're doing this to help the community. When the guidelines are no longer clear, you don't know what you have to do to help the community. So you just do it for yourself. And I think it highly likely that we'll see under those conditions worsening of mental health. And of course, people lower down in the hierarchy, as I showed with that slide from the US, their financial circumstances are getting much worse. People higher up are fine. They can work from home. They can spend less money, so their wealth is increasing because they can't spend money on all those things they used to do. So their wealth is increasing, and people lower down, their wealth is decreasing and their resources are decreasing. And that has a negative impact on mental health.
Yeah. Okay, thanks, Michael. I'm now going to go to the most recent question and direct this to Philippa, which is asking about the wellbeing centred policies of New Zealand, which the questioner notes echoes the Bhutan Happiness Centre government policies. But she's asking, how efficient are those policies against powerful social, economic, political actors who do not value health or happiness or care about ecosystems? So, and they're more interested in short-term gain. So that's a big question, Philippa, but I might also see if Deepa and Francesco want to address that one as well. You need to unmute. Yeah.
And New Zealand, it's certainly Bhutan had took the prize of first having a well-being and happiness, emphasis on happiness. It's the Minister of Finance had been considering having a wellbeing budget when he was in opposition. There was a lot of interest in meeting with Amartya Sen, and Treasury had been doing a lot of work on it. So there was very considered. For a long while, it was considered a bit fluffy by business, and sort of they thought that the government would go away. And interestingly, the government's lead, we have a mixed member system where it's not first past the post, that the government's lead now can govern alone. The government is in a much stronger position than it used to be, and it's moving and going to move very fast to implement across the whole wide area of the well-beings in a quite profound way, and indicated by the fact that I think about a quarter of the government positions are Māori ministers of health, and there's half the cabinet is women, and it's transsexual people and intersex people. it's a real rainbow cabinet, and so I think that's it's social inclusion of the political process of governance, and of course there will be mistakes, but the government is moved away 3 years ago from the austerity budget and of the previous government, and it's really moving to say there's so much we have to do to try and remediate infrastructure, social and physical, and we're going to go for it while interest rates are basically zero. And so, yeah, come and visit us when you can. It's pretty interesting.
Yeah. Okay, well, I think we're getting close, so I might just ask each panelist to make any final comments, and I don't think we're going to have time to get to all the questions. So I might go in reverse order and ask Francesco just to make a closing comment or two.
Thank you very much, Fran, and thank you for the very interesting discussion. So my final point is about the future and about the need to take opportunity of this crisis to build back better. We have really, unfortunately, this perfect storm of the disaster of climate change, the economic crisis, the health crisis. We cannot continue like that. And this is completely unsustainable, increasing social contrast. We cannot continue to live in this world. Particularly because the world will be 10 billion in a few years. This requires drastic action. I hope this is something that all citizens will be aware of, and they will push the governments to take the necessary action. So I think that's what we need to work on. In food, to reconstruct, to rebuild food system, make it more resilient to crisis, make it more equitable, make it driven by health and environmental consideration and not by profit. So that's, I think, the commitment to the future. Thank you.
And thank you very much, Francesco. And Deepa, quick comment?
Very quick, just to echo Francesco also, I think we need to really look to the future, and this crisis has clearly shown us that it can't be business as usual anymore. And so some of the things, many of us, like the PHM, that health systems have to be more equitable, food systems have to be decentralized and equitable, and that these are not in their own silos, the food, health, environment, overall equity, that they're all linked, and it's a different economic system as well that we need to think about.
Fantastic, Deepa. Thank you. Philippa?
And I would agree with that. And one of the things that lockdown showed us is that carbon emissions went way down, and there's been a lot of discussion. This is what it could be like if we're really going to be carbon neutral by 2050. And that's been quite profound in terms of gardening and walking and an increase in those kind of things. Yeah. I think we also using, Francesco, that expression, build back better. And I think that's a good mantra for the era.
Okay, thanks, Philippa. And Michael, a final comment.
Very much agree with Francesco that we need to put the climate crisis, action on the climate crisis, and action on inequalities together. And I was very interested when a group published the Social Progress Index, that if you compare 3 countries, Germany, the US, and Brazil, Germany handled the pandemic very well, the US and Brazil very badly. And on several of these indicators of social progress, Germany looked fine, high, and no decline. The US and Brazil declined. Now, that's not correlation, even let alone causation, but it's saying it's not just democracy or autocracy, it's how your democracy works. Are you working in the interest of the population, social progress? And it looks like the countries that were working in the interests of their population handled the pandemic better. And that needs to be the basis for building back better.
Okay, well, thank you very much. Thank you to all four speakers. I think it's been an amazing session. We've really emphasized the dangers of increasing inequities, the importance of reducing those, and doing so in a way that's sustainable for the future. And I think the other thing that's come out is the importance of government. You know, government is not a bad word, it's a good word, and the public sector is very important if we're going to take action on all these fronts. And I think, Deepa, you talked about the importance of universal services, and I think Philippa also stressed that. So that is really very important. And that public policy can be regressive or it can be progressive, and it can really help us achieve the aims. So thanks to all of you. I think the other important thing that I think is, and speaking with a People's Health Movement hat on, is the importance of civil society in shifting governments to take the sort of view Michael was talking about, so that their efforts are for social progress for the population, not for the interests of a small minority. And I don't know what democracy you were thinking about, Michael, when you said they're different democracies, but I do think we have an example of that going on in the background of everybody's minds at the moment. So just to finally close the session, when you sign out, you will see a pop-up question, and we want you to evaluate the session so we can have some evidence. We're all committed to evidence-based, so that would be great. And I'd also like to tell you that the next session coming on PMAC is WS203, Making International Intellectual Property and Trade Regimes Work to Address the Health Response to COVID-19. And it's on later tonight at 9 o'clock Bangkok time. And so finally, I'd like to thank PMAC for asking the People's Health Movement to coordinate this session. And I'd like to most of all thank our speakers, Dr. Francesco Branca, Dr. Deepa Singha, Professor Philippa Howden-Chapman, and Professor Sir Michael Marmot. It's been a wonderful session, and your contributions were just amazing. So good night, everybody, or good day, or good lunch, wherever you are in the world. Thank you so much for joining us.